So we had lots of great questions during our session, but we'll open it up to additional questions for the last 15 minutes. If you have anything you want to ask us, the floodgates
I
are
also
open.
checked the app, and I didn't see any questions on the app. Did anyone submit a question on the app?
Here, we don't have any questions yet, but you can look here.
Okay,
now.
if you submitted a question on the app, we don't have it.
We have a question right here.
Go ahead.
Do we have a microphone
That
moves around maybe?
Someone behind.
Yeah, I can repeat the question too, but yeah.
So you mentioned, someone mentioned about cognitive behavioral therapy being easily accessible on apps and things like that. I mean, I'm aware of the relaxation apps. I haven't heard about the cognitive behavioral therapy apps, or is there a way like you have to give?
Yep. So the question is, what apps exist for cognitive behavioral therapy? Do you want to take that one, Dina?
Sure. So there are a number of psychology sign-up programs online now. Just as an example, BetterHelp is one of them. And some of these platforms have pain psychologists who are trained in cognitive behavioral therapy. It depends. That depends.
There's also like Calm and Headspace and
Yes.
yeah.
Yeah. So if you go to, it's betterhelp.com, that's just one example. Now there's dozens of psychology programs that patients can sign up for. That's just one example. You can go onto the platform and you can find people in network, out of network, or you can submit the bill to insurance, of course.
Another question?
How often do patients who are pregnant and eligible for preventive treatment after you discuss everything with them, they choose to go with preventive treatment, or just stay away from any medication during pregnancy?
So the question is, how often do pregnant patients elect to start preventive therapy? I think it's completely individualized.
I'm asking about your practice.
Oh, in my practice, like I got a lot of different kinds of patients. So, I think that if they're coming to a headache specialist, there's a bias because I think that the intensity and disability associated with their headache is somewhat higher. But I think that when you discuss the benefits and risks, most people say, sign me up. Not everyone. And it also depends on when in the pregnancy they are. And so if it's early on, I say, okay, well, it's possible that your headache may naturally improve in the coming 3-4 weeks, we can hope. You can start a preventive therapy now, or you can wait and see and lean on our acute treatments. And there's a lot of variability about how patients choose to move forward there. I hope that answers your question. Yes? Yeah, that's a great question. So the question was, how often do you see improvement or worsening with exercise? I think that's also a bit individualized, but there's data to suggest that I think it's sort of mild to moderate exercise can be a benefit for migraine, but then there's lots of us who, when we are in the throes of a headache, we just don't want to move, and exercise can actually make people feel worse. So that's another thing I just tell my patients, listen to your body, and when you can, mild to moderate exercise is helpful for your overall health, for your brain health, and potentially for your migraine. But if you just are not feeling it today, listen to yourself.
Can I say something controversial too, to that token? The International Classification of Headache Disorders, for me, is not a great diagnostic tool because there's so much variability. And one of the criteria they have on there is worsening on exertion. And so oftentimes when we see patients who worsen with exercise, which is extremely common, right? Patients say, I get a migraine right before when I'm gonna run my marathon or play soccer or whatever it is. That causes us to feel a little alarm, right? That there's something else going on. And we want to rule out those secondary causes, but I think it's extremely common, and I think we really have to expand that diagnostic criteria so that we have more comfort signs about what migraine really is, neck pain, vertigo. We have worsening on exertion, but we can be a little more specific about that, I think.
Yes.
Yeah. So there is a historic concern about the use of triptans in people with either hemiplegic migraine or what used to be called basilar migraine and is now called migraine with brainstem aura, on the theory that triptans cause intracranial vasoconstriction and there is an increased concern for stroke with the use of triptans in those patients. And as I understand it, it's because if you have a migrainous infarction of during hemiplegic aura, the symptoms are going to be potentially more disabling than they would be with other kinds of aura. I don't necessarily think that that's true, and we also know that triptans do not necessarily cause intracranial vasoconstriction. There are a number of studies that show that that is not necessary for treatment efficacy. So over time, we have started to see a little bit of pushback on the prohibition against using triptans in those populations, and there have been some expanded case series of use of triptans in those patients without adverse events. What I would say is that I think most of us still prefer to try other things first, and if nothing else works, I think most of us at this point would feel pretty comfortable trying a low dose of a triptan in that situation. At least that's my practice. I don't know what you do.
Agree.
I would agree with that, but also we know that in general for aura, cortical spreading depolarization is a very, we know that there's a lot more evidence for it in aura. I might try transcranial magnetic stimulation, and a device that's supposed to slow that process down. That's another consideration.
Yes. Yeah, so a couple things. The question was, for those of us who practice in the hospital setting or an ER setting, what's your approach? First and foremost, I think we're obligated to rule out a potentially dangerous cause of secondary headache, for sure. Once you're pretty settled that you are dealing with an exacerbation of primary headache, there are a variety of different acute options. I think most headache specialists, it's like nails on a chalkboard when people say migraine cocktail, because, do we say epilepsy cocktail? No. I think it sort of, minimizes headache to something that can be easily treated with a cute little cocktail, So just say that my residents are like, yeah, we know, Dr. Rahill. But yeah, just use the names of the drugs. But in my practice, it depends on the patient, of course, but I'll reach for something like prochlorperazine or metoclopramide. I'll usually give diphenhydramine to minimize any extrapyramidal symptoms. But don't forget about triptans, injectable triptans, or dihydroergotamine if they haven't used a triptan within 24 hours, provided their blood pressure is okay. Steroids can reduce bounce back to the ER within 24 hours. Would you guys add anything to that?
You could consider doing nerve blocks with bupivacaine or lidocaine in the emergency room. Bupivacaine is longer acting, so I have better experiences with it in my practice. You can do nerve block and trigger point injection if you wanted. And then magnesium 2 grams is also pretty easy to use in the emergency room, in addition to everything Dr. Rahill said.
And NSAIDs like ketorolac, et cetera.
Yeah, so that's what we do as well. We do all of those things. We tend not to do triptans because our patients have used them before coming in. And we sometimes do DHE, but usually we admit for that. But the other thing that we do a lot at my hospital is valproate infusion, and
Same.
that often helps as well.
Yes.
No, I was just going to add, we have, interestingly, we have 24-hour data for 2 of the CGRP preventive treatments. For atogepant, which is the preventive oral tablet, and for IV eptinezumab. So sometimes it's important to consider that preventive initiation, if possible, when you're treating status migrainosis, but I know in the emergency room it's hard.
Yeah, my hospital does not carry that stuff.
We don't either.
Yes, back there. Yeah, that's
Yeah,
a
I
great
can-
question. So the question is, in people with cerebral ischemia like TIA or stroke, do you have any concerns about CGRP-related medications, right? So CGRP is an interesting vasoactive peptide. So it's like everywhere. It's one of the most potent vasodilators in the body. And so when these drugs first came out, all the headache specialists were kind of bracing ourselves for uncontrolled hypertension, which we are starting to see more of. MI, stroke, all these scary things. And knock on wood, we have not really seen evidence for an increase in these sort of, cardiovascular events that I'm talking about. But I think there's some theoretical risk there. And in my personal opinion, because I think Gepants are a much safer option for patients with cardio and cerebrovascular disease, certainly over the triptans. So I'm very comfortable using Gepants in that case, and especially if it's they're short-acting medications, right? So they can get out of your system quickly. But I do discuss with my patients about the monoclonals because they last so long in our system, and so. I think there's some animal data to suggest that I forget if it was like a rat or a mouse or something, they actually tried to simulate cerebral ischemia, and in the presence of CGRP inhibition, it led to a decrease in the ability for that mouse or whatever to rehabilitate. And so there's some theoretical concern that the presence of a CGRP inhibitor may prevent that expected compensatory vasodilation that happens around an area of ischemia. And so although we have not seen that in humans and in clinical studies, I actually share this information with my patients and say, risk is low, but because these things hang on for forever, let's talk about the benefits and risk depending on their specific vascular risk. Do you guys want to comment on that?
Yeah, so the other thing to be aware of is that the clinical trials for CGRP monoclonal antibodies excluded people who'd had cardiovascular events within the last 6 months. So we don't have safety evidence for that population. And for that reason, there are many headache specialists and neurologists who prefer to wait until 6 months after a cardiovascular event to start a CGRP monoclonal antibody. The difficulty is when you have somebody who is on CGRP monoclonal antibody and has a cardiovascular event, and the question is whether you stop it or not, and that's the place that we don't have a lot of evidence. I will say I just had a recent experience of a patient who had a stroke on a CGRP monoclonal, and we had a very long conversation. She really wanted to continue it. We continued it, and she had another infarct. And at that point, we decided to stop it. So obviously, anecdote is, it's an N of 1, and we can't really extrapolate from that. But I think it does highlight the need for more information in this area, and I don't think it would be wrong to stop a CGRP targeted, particularly a monoclonal antibody in that population, particularly if the patient is high risk in other ways.
So we have 30 seconds. Who's got a quick question? Okay, you got a quick
So
question.
for patients with the medication overuse headaches, besides stopping the causative drug and starting them on a preventative medication, is there any medication that can break the cycle?
Yeah, so the question is for patients with medication overuse headache, do you do anything else besides institute preventive therapy and switch acute therapies, right? So, and there was a question about transitional therapies, as we tend to call them. So for me, I give it to the patient. I say, we could add a short course of steroids to help in this transition, because people often get worse before they feel better in this situation, as they sort of restore those thresholds for headache coming out of medication overuse. You can do things like peripheral nerve blocks and other things, and so it's a patient discussion, but you should use all the tools you can to help them out of that predicament. All right, I think we've run out of time, but thank you so much for joining us. Thank you, thank you.